Thank you very much, Sanjay. Thank you for inviting me. And it's nice to be able to stand up here. My talk's going to be very different from the last one. Very few RCTs, and it's going to be really based on our experience at the Homerton. When we started doing bariatric surgery, when Kay Minor started in 2001, and I was asked to scope a patient who'd had bariatric surgery, it was entering a new world. And there weren't any courses to go to at the time, and I had to sort of find my way, really. So over the years, we've got some experience of dealing with these issues, but this is a problem that's going to be mirrored by lots and lots of endoscopists around the world as the number of bariatric procedures goes up globally, and endoscopists need to be aware of the pitfalls and the issues that are going to be raised in this particular cohort of patients. And they're a very interesting and very challenging group that I'm sure you'll agree with. So in 2015, we published our data looking at sort of a roughly about 3.5 years worth of experience at the Homerton. And you can see that bariatric surgery took off in the late 2000s. And you could see also that the proportion of bypasses to sleeves was very different to what it is today. But it was one of the first papers to come out, and when we published that there is a significant morbidity associated with bariatric surgery, it was in the Daily Mail the next day, and Dr. Shadrawi says bariatric surgery is bad for you, and my name was mud at bombs that year. So it wasn't intended to be like that. It was really just to help people in the consent process. When you're consenting your patients for a sleeve or a gastric bypass, to say, well, you know, you're 100% likely to get a heart attack and 100% likely to get a stroke if you carry on with a BMI of 60. But if we operate on you, we'll reduce that risk. But there is a small risk of leaks and risks of perforation, risk of strictures and things that could happen that we have to accept if we're going to improve your life expectancy. And we've subsequently have published and become much more open about talking about the complications of bariatric surgery. And these patients present with mainly this sort of vague group of symptoms that Andrew mentioned just now, and that it's very difficult sometimes talking to these patients to know, are they talking about reflux, or are they talking about the food sitting in the sleeve and not moving anywhere? They describe often this pain when they eat and the food sits there and it gets unbearable, the pain gets unbearable, and sometimes they have to make themselves sick to bring the food up. It's a whole constellation of symptoms that often get lumped as reflux, and often it's regurgitation, and it's sometimes dysphagia or odynophagia, and sometimes it's very difficult to tease one from the other. And is it nausea and vomiting, or is it induced vomiting because they feel better when they've relieved the food, and have they been eating too quickly, or have they is it something to do with their lifestyle and their eating habits? But and so classifying these symptoms can be really difficult, and we've subsequently gone on to analyze our later data more recently, and you'll see that the numerator is down, so the numbers are less in roughly the same period of time. So our complications that we're seeing as endoscopists are coming down happily, and we're finding that when the disasters happen, it's often patients that have had surgery either abroad or by other units in the private sector, and in centres where they've standardised their practice, then we're finding a significant decline in the incidence of complications. So what are the problems that we see? The first one, and the most common one that I see, is the so-called, what I call rectalisation of the sleeve. And I brought this piece of paper really just to demonstrate what I mean. But when we see patients who complain of nausea and vomiting, or discomfort after they eat, we go in and we find this phenomenon that I call rectalisation of the sleeve, which is basically you go into the stomach and you find that there are very tight corners in the sleeve. And the best way I can describe it is when you do a sleeve, ideally it should be a nice long tube, but if the sleeve is twisted in any way, when you apply the staples, that produces kinks on the inside of the tube, as you can see from that. And when you look at these patients endoscopically, the first thing that strikes you is how much reflux they've got. And they've got signs of reflux, and you've got streaky esophagitis there. And when you go into the stomach, the first thing you see is a pool of acid and some bile sitting in the proximal half of the sleeve, and then it looks like you've come to an end there. And you have to negotiate that tight corner through there until you finally see what you're looking for, and that's the pylorus. So they often have this sort of kink, and sometimes it's one kink, sometimes it's several kinks in the sleeve, and that's a very common finding. And is it any surprise that these patients are refluxing? Clearly not. And sometimes these patients will need corrective surgery to correct that. The other feared complication that I see is the anastomotic leak, and they always occur at the angle of His at the proximal end. And is that because it's a watershed area? Is that because it's a high pressure area that you've been hearing about in the last couple of days? Clearly, it always happens there, and that when that happens, patients are in for weeks, and it's a disaster. So this is an example of such with a nasojejunal feeding tube in the true lumen, but you can see a very well epithelialized hole there. That's the healed fistula that's persisted and communicates with the left upper quadrant fossa. Well, there's a picture there that shows you what we've done with this patient. We've placed one of these bariatric stents, and there's a nasojejunal feeding tube, very importantly, that's feeding these patients downstream. And you can see there's various stents on the market now. That's a Hanaro stent that we placed at some stage in the process, and their management we'll come to that in a while. There's another concept I want to introduce you to that I haven't really heard much of in the last couple of days, and that is when you do a sleeve, you see 5 different sleeves and they look different. And it really depends on how much of the antrum is removed. And remember that the vagal innervation to the antrum is mediated on the right by fibers that supply the pylorus, and on the left by fibers that supply the antrum. And that is responsible for something called pyloroantral reflex. And if you cut the vagus in different ways, you affect the pyloroantral reflex in different ways. So I can see 5 different sleeves have 5 different effects on the pylorus. And when we go down the sleeve, sometimes the pylorus will be very stiff and won't relax. And so one of the reasons why the data is so confusing when you look at the physiology in patients who had a sleeve is because every patient will have a different effect on their pyloroantral reflex. And so gastric emptying is affected in different ways. And if we can focus more on what's happening in this downstream, then maybe we can start to understand why these patients reflux. And so sometimes the pylorus will be very stiff, and sometimes it'll be gaping and it'll be open, and you'll be able to go through very easily. So we need to think more about what's going on downstream in your sleeves, not just what's happening at the lower esophageal end. And there's a very easy treatment for pylorodynia. You can inject it with Botox in the 4 quadrants there, and if that produces a beneficial effect on the patients, then you can offer them an endoscopic balloon pyloroplasty. And when we started doing this, we saw some really dramatic results on their reflux symptoms. But then after a year or 2, these patients were coming back to me with a big frown on their faces because they'd regained some of the weight they'd lost after their sleeves. So now when I see patients that I think might benefit from either intrapyloric Botox or a balloon pyloroplasty, I say to them at the end of the sentence, I'll make you better, I'll make your reflux better, but you may regain your weight. And when you tell them that, they say, oh, no, I'd much rather have my reflux than gain weight again. So just beware that things that happen more downstream are very relevant to the reflux story, and improving that may improve their reflux symptoms, but may cause them to regain their weight. And of course, there's this problem that we see with anastomotic ulceration, where you can get what's so-called marginal ulceration, and this is particularly in the group of patients who smoke, who have H. pylori, who take non-steroidal anti-inflammatories, and are amenable to medical therapy. So that's the sleeve side. If we look at the Roux-en-Y gastric bypass patients, again, these are different patients. They all look different. Some have big pouches, some have little pouches. Some have tight anastoma, gastrojejunal anastomoses. Some of them have very wide anastomoses. So no two bypasses look the same to us. And one of the few rare, happily rare, but recurrent problems is the problem of the gastrojejunal stricture, the anastomosis. And initially we used to dilate these initially very gingerly with balloons, and then more vigorously with bougies. But what we've been doing, I'll show you in another slide, is stenting these, and with much better success rates. The other problem we come across is gastrojejunal ulceration, and that can become a chronic problem and eventually lead to the stricture and can be very difficult to manage. The gastrogastric fistula is a big pitfall that endoscopists can miss very easily sometimes. And that's often made radiologically, often before we scope them, but is an important one to recognize. And this is a patient with a gastric bypass, where that's the natural lumen. But if you go through this hole up here, you find yourself in the excluded gastric remnant. And so this is a case that we did. We placed an Ovesco clip-on eventually and resolved that way. Over 50%, and we've published on this, of our patients will have normal anatomy in the bariatric setting. So they come to you and they tell you, food sits there, it doesn't do anything, it feels awful, I can't eat anything, the food sits there and then eventually has to come up again. And you go down there thinking you're going to find a stricture and you're going to find something, and in fact, the anatomy looks perfect. It looks like a textbook bypass. And these patients often have a dysmotility problem. And then when we do a contrast study, we'll find that the contrast sits in the upper proximal part and sits there, takes for a long time to get through. And they have genuine dysmotility. And again, that's to do with what nerves you may have cut and what you may have done to the motility of that patient, which has nothing to do with an anatomical defect. So always remember, if you don't see a stricture, there might be another explanation for the problem. And sometimes we've seen this where you get a sort of a valve effect where patients can tell you that they sit there and they vomit intermittently from time to time. And when you look down below, sometimes that can be missed on the radiography. But when you look endoscopically, sometimes you might be lucky enough to see a sort of a valve effect produced by the gastrojejunal anastomosis. And that often can explain their symptoms, particularly if it's intermittent. So this is our data that we've looked more recently, and this is what we've had to deal with to give you a rough idea of the sort of frequency with which we have to treat these patients endoscopically. And what have we done? What modalities of endotherapy have we used and tried over the last 20 years? Well, we started with, for example, the gastrojejunal stricture, dilating them by bouginage. And more recently, we've been using these short cisgastrostomy stents that I use for pancreatic pseudocysts. We've been using them for the short gastrojejunal strictures. And this was a patient that I met a couple of years ago now, who had an albumin of 11 when I met her, and was very malnourished and had terrible ischemic heart disease. So no anaesthetist was willing to put her to sleep. And we tried to dilate her, and her symptoms would come back within 48 hours. So I thought of putting this short 3 centimeter stent across the gastrojejunal stricture, which is a very short stricture. And you can see the wasting of the stent there. And literally the next day she was eating and drinking almost normally. So these are 30 by 16 millimeter stents that are sort of look like a Babcock that we use for cysgastrostomies. And it works very well for these short strictures. And she ended up having these stents replaced at 3 monthly intervals over a period of about 18 months until her cardiologist said she could go ahead and have surgery and have that refashioned. So it tided her over to get her fit enough for surgery. And then with the leaks, this is one that came to us having had an Ovesco clip attempted before, and that was sitting there floating in the wind, wasn't doing anything. And her contrast study shows how she fills up this big hole at the proximal end of the sleeve. And this patient was managed by a combination of percutaneous drains, nasojejunal feeding, bariatric stent, and that kept her going until her albumin, very important, albumin, which was initially 15, was up to the high 30s before we attempted an Ovesco clip on her, and it actually worked. So the lesson, one of the key take-home lessons that I've learned over the years is that you might be able to do an endoscopic intervention on these patients, but if their albumin is poor, they won't heal, and the clips or the stents, the clips won't fix, the fistulas won't heal unless you get them nutritionally replete. And so now, before I let anyone near a patient to do anything, I'll make sure that they've got NJ feeding in. I monitor their albumin to make sure that the albumin level goes up into the high 30s before we attempt anything. And this patient had a stent initially with the nasojejunal feed there, and eventually had it clipped, and she got better. For marginal ulceration, we've tried something new recently. In addition to all the lifestyle things and HP eradication, we've tried Purostat. And Purostat is this magic secret formula that's supposed to improve cross-linking of collagen. And so what we do is we have to rub the ulcer and de-slough the ulcer, apply this clear gel over the ulcer, and then put some clips on, some normal hemostatic small clips in a series all the way along the ulcer, and we've had some really good results with these marginal ulcers. We haven't published that yet, but you're the first to know about it. The other thing we're very excited about is the Evo sponge. I've used it in the pelvis after the anterior resections, and I was really impressed by how quickly the abscess cleared up. We've also used it in the esophagus, but we haven't yet seen a sleeve leak big enough to allow us to deploy the sponge and use it, but I'm sure it'll be a valuable addition to our armamentarium. The other thing I'm interested in using the Evo sponges for the pancreatic abscesses after you've placed the cysgastrostomy, because I think that would work very well. But that's something that I'll be watching with interest over the next few years to see if that helps in managing your patients with sleeve leak. And then, of course, the dysmotility patients, you can try them on prokinetics, but it doesn't work. So they end up having revision surgery. Other things that are really important for managing these patients from an endoscopic point of view is don't underestimate the importance of placing these nasojejunal feeding tubes. They're now very thin, very flexible. They're double, triple lumen tubes now that's made by Fresenius, that's got a 15 French gastric port, a 9 French jejunal port, and has an air vent as well to decompress the proximal stomach. These are really useful, and we use active aspiration techniques to keep the top end dry and feed them beyond the pylorus or downstream, and that helps with their nutrition and improves the patients prior to surgery. Don't forget the role of endoscopic ultrasound in draining some of these collections. You've seen the French put pigtail stents into these collections. That can be done easily by EUS under EUS guidance. So we've got various techniques we've evolved over the years about how to manage some of these very thin fistulas with very small internal openings that spread out like a sort of cobweb after leaks, and cleaning them is really important, using non-irritant glues to inject into them, and then applying Ovesco clips has worked over the years. And then, of course, the endoscope can come in handy when you've got a stone in the duct, we've done quite a few of those very, very easily. At the same time as patients are undergoing a laparoscopic cholecystectomy, they create a port, as you saw in the video yesterday, and we can access the ampulla in patients who've had a gastric bypass to clean the duct and do an endoscopic sphincterotomy. So this is our data, again, compiled over the last 3 years about what we've done. And happily, these numbers are coming down over the years. And the take-home messages, my last slide, which coincides my time, is that endoscopy after bariatric surgery is common. We need to train our new generation of endoscopists to recognize what the insides of your anatomical reconfiguration looks like. Bariatric complications, unfortunately, are common and are not uncommon, I should say, and that they've got a whole armamentarium of things that we can use to help these patients. But most importantly, I think you really need to remember to feed these patients before trying anything heroic. Thanks very much.
Thank you. That's a great talk. Can I ask you about the incidence of complications? You mentioned that the complications have reduced. What are the factors helped in reducing the complications here?
So in our initial paper that was published in 2015, we saw 150 cases, and I looked at the numbers of bariatric operations we'd done, and it was basically the denominator was about 1,500. So our initial ratio, I would say, was about 7.7%. But most of the complications that we had weren't actually homegrown. Because we're a bariatric center, we were getting all these patients who just landed from their sleeve in Turkey or wherever it was, and they were coming straight to us because we had the experience. So in that period, we saw about 150 patients. And then in the second equivalent period, since 2015, we've seen about 90 cases. So there's been a reduction clearly. Why? I think that's because we're standardizing the way we're doing bariatric surgery. So I know at the Homerton and at UCL, where Andrew works, you enter this, once you're in the operating room, you work in a very, very set way, and you do things in a very set way. And that must surely be a good thing, and that must be one of the reasons why incidence of homegrown complications is coming down. But certainly, anecdotally, the complications are less.
Thank you. Any questions from the audience?
Do you do the endoscopic, the general anesthesia, or the anesthesia?
No, the ones I've done have been under local, just some midazolam.
That's very good, because one of the drawbacks of the endoscopic is the frequent need for the
You have to change it every twice a week.
If you don't need a general anesthesia, that's quite good.
Yeah. But the reason I haven't been able to use it is because usually the orifice is so tiny, and the leaks that I've had, I haven't had great big holes. You need quite a reasonable size to place the sponge.
Right. You put any pigtail stents?
No.
That might be an idea.
Yeah, I picked that up yesterday. The French apparently in Montpellier are using that. It might be an easy, and I do EUS guided stenting all the time, so it might be something that we could do.
Ray, thanks very much for that. Do you put in any gastric balloons?
Yes, I was the first person to put a gastric balloon in 1998, and I had. Did you put them in before then?
You just beat me.
I was one of the first, and the problem I had with the balloon, and we're still using exactly the same balloon today that we used in 1998, is that a third of patients ring up the next day saying, I can't bear having the balloon in. Another third do very well, and another third lose the weight very, very well, but then put the weight back on very quickly. And that's why I've just gone off the idea, and I have, Andy knows I do other things to sort of help people lose weight, but I came off the idea of balloons, and I spend now my time taking balloons out in patients who've gone to Czechoslovakia and
Nonetheless, there are balloons put in the UK by endoscopists. Should they join BOMs and record their balloons in the registry?
Yes, I think so.
How do we do
Especially these newer ones that are really untried and untested, that we're hearing are causing obstruction, and at the moment it's unregulated, and it's very worrying. I don't put any other balloon than the balloons I'm happy with, that I know we're not going to burst mid-air or when people are travelling or in another country. But I think especially with these newer ones coming on the market, there has to be some post-surveillance where you can monitor these things. And I'm often asked and approached by the manufacturers, would you be interested in putting these balloons in? And I push them away, really.
So no answer to how we get the gastroenterologists on board.
I think not only the gastric balloons, but now the endoscopic sleeves, all endoscopic procedures are being done by gastroenterologists without any training in obesity surgery.
Oh, these gastroplasties. Yeah, I'm not a big fan. I mean, people tell you I'm pretty invasive when it comes to it, but I've never really been convinced by any of these anti-reflux procedures. I mean, they said the stress takes an hour. Well, I know some laparoscopic surgeons can do a fundoplication in 30 minutes. So, it's difficult to justify a lot of these endoscopic procedures. And the reason you've got so many endoscopic procedures is because none of them work. If you had a really good one that worked, you'd only have one.
I think having done nearly 50 endoscopic sleeves, we can.
Yeah, I'd love to. Love to convince me otherwise.
Thank you.
Thank you. Thank you very much.